So our penultimate speaker for the day is Professor Ingrid Scheffer, who is going to present Shedding Light on the Sacred Disease, Epilepsy Genes Reveal Novel Mechanisms.
Thank you. Sorry. Thank you very much, and I'd like to thank the Academy and my supporters for the great honour of being elected to the fellowship. Turning now to the sacred disease. Turning now to the sacred disease, epilepsy has long been known as a sacred disease, as depicted here in the image by Raphael in the early 1500s, where Jesus is curing the child with epilepsy. When I started in epilepsy genetics some 23 years ago, there was still considerable cynicism that genes played a part in epilepsy at all. Epilepsies are common diseases with up to 5% of the population having a seizure sometime in their lives. And there are many types, and here you see a 21-monther having a cluster of myoclonic seizures triggered by the flashing light.
Typical one again?
Yes. When we think about epilepsy, we broadly break it into two large subgroups. The generalised epilepsies, which involve bilateral corticothalamic circuits, and focal epilepsies, where the seizures begin in one part of the brain. Historically, the generalised epilepsies were considered genetic, but largely thought to follow complex inheritance, where multiple genes were involved, and the focal seizures were considered acquired. And in fact, when we think acquired, we think of scar or tumour or malformation, and here you see the commonest structural cause of uncontrolled focal epilepsy, which is hippocampal sclerosis. And this is a surgically resectable lesion. Now, with that as background, I'd like to share with you two different stories, the first on focal epilepsies and the second on generalised epilepsies, particularly pertaining to the severe epilepsies of infancy and childhood. So the first part of the research story is that focal epilepsy can indeed be genetic, and in particular non-lesional. That means where the brain has normal structure on imaging. And here you see a girl with a disorder that we described about 20 years ago called autosomal dominant nocturnal frontal lobe epilepsy. This little girl does this 8 times a night. She is aware through it. She's scared, as you can see by her face. And she goes to sleep and does it all again in 10 minutes time, and this affects her daily function. When we first started with this disorder of autosomal dominant nocturnal frontal lobe epilepsy, we were referred to small families from Adelaide. A year of clinical research later, we had a pedigree like this, with 27 affected individuals over 6 generations. They all had this same disorder that I've described, and then with the assistance of Grant Sutherland and John Mulley, this family was mapped to chromosome 20q, and together with Ortrud Steinlein, the first epilepsy gene was found, and it turned out to be a neuronal nicotinic acetylcholine receptor with the mutation right here at the ion channel gate. And this really opened the door for the epilepsies to be considered a group of ion channel disorders, and now we know that sodium, potassium, calcium channels have all been implicated in different epilepsies, as well as nicotinic receptors and GABA receptors. So moving from there, I want to move to a second focal epilepsy that we described a few years later, which is called familial partial, and we now use the term focal, epilepsy with variable foci. And this was a little different in that within the family, different individuals had focal epilepsy originating in different brain regions, for example, the frontal lobe, temporal, parietal lobes. Here is our original Australian family, and you can see the individuals in blue have temporal lobe epilepsy, those in red frontal lobe epilepsy, and this chap here has parietal lobe epilepsy. So fast forward then to 2012, we have 2 more members of the family, 2 boys, one with temporal lobe epilepsy, but interestingly both have autism spectrum disorder, as does the uncle, and 2 individuals have intellectual disability. So this family was used by my colleagues in Adelaide, Leanne Divins and her team, to use whole exome sequencing to find the gene that causes this disorder of familial focal epilepsy with variable foci. And this gene is called DEPDC5, and in good Australian tradition, I'm going to call it DEPDEC5 because it's much easier. So we then looked at the 8 families that have been published with this rare disorder and found that 7 out of 8 families have a mutation of DEPDEC5. Well, that's all nice and interesting, but you can say it's a rare disease and we've cracked this rare disease, but where does that take us? So then we asked the question, is DEPDEC5 relevant to common or garden focal epilepsy? And focal epilepsy accounts for 60% of all epilepsy. So we looked at 82 families in which 2 or more individuals had focal epilepsy, and this is what we found. 10 of the 82, so more than 10%, had DEPDEC5 mutations, and these did not necessarily have that pattern of variable foci, in that some families just had frontal lobe epilepsy and others just had temporal lobe epilepsy. So you wouldn't necessarily think of the disorder that we first recognised in a large family. What was very exciting was a couple of months after we published this last year, the Sabatini group at MIT in Boston showed the function of DEPDEC5, and it is a player in the mTOR pathway, which is a key regulator of cell growth. And here you see DEPDEC5, and it's actually a negative regulator of cell growth, so that where you have amino acid deprivation, DEPDEC5 stops cell growth. There is another very well-known player in the mTOR pathway and medically very relevant called tuberous sclerosis. And this is a neurocutaneous syndrome where individuals often have severe focal epilepsy, intellectual disability and autism. And it's known to be due to 2 genes, TSC1 and TSC2 mutations, both important in the mTOR pathway. Tuberous sclerosis is associated with tubers, abnormal growths or malformations on MRI scan. And so this obviously led us to the next stage, which is could DEPDEC5 mutations cause brain malformations? And here we have the answer. Here we have a family that we've studied over about 15 years, and this family, as you can see, has 6 affected males, and they all have 5 of them had frontal lobe epilepsy. And what we'd observed in this family was that 2 of them have malformations, but the remainder do not. And these 2 both have focal cortical dysplasia, which you can see here and here, where there is blurring of the grey-white matter junction. So we have the answer here that DEPDEC5 can cause both lesional and non-lesional focal epilepsy within a family. So this work has really shown that focal epilepsies can be genetic. One gene causes both lesional and non-lesional epilepsy, and in both DEPDEC5 and in tuberous sclerosis, we know that you can have familial and de novo mutations. That by finding these mutations, we reveal novel mechanisms, and ion channels are well established now in epilepsies, but the mTOR pathway is obviously going to be important in milder epilepsies as well as severe ones, and there are likely to be many more. These mechanisms are a way of leading to targeted therapies, and we already know about mTOR inhibitors that work in tuberous sclerosis. So the critical question now is, will this help the more common focal epilepsy? And if we can target these mechanisms, we would hope to improve the outcome and the risk of comorbidities, such as intellectual disability and autism. Now, the second part of my talk, I wanted to move on to the severe epilepsies of infancy and childhood, which are called the epileptic encephalopathies. And these are very complex electroclinical syndromes, and I like to think about them as a puzzle where you need a number of different components to make a diagnosis. The best known of the epileptic encephalopathies is Dravet syndrome, and to set the scene for the next study, I just need to describe this to you. It begins in a previously normal baby at 6 months who presents with prolonged febrile seizures. They develop a range of other types of seizures. Development is normal in the first year of life, but then they regress and usually have intellectual disability. They have a number of late features, such as a crouch gait that we've described. The EEG shows generalised and focal epileptiform features. And the gene was found in 2001, and we now know that more than 80% of patients with Dravet syndrome have a mutation of SCM1A, which encodes the alpha-1 subunit of the sodium channel. And most of these mutations arise newly in that child. So that completes our puzzle for Dravet syndrome. Now, with that as background, I'd like to tell you about vaccine encephalopathy. And this Times header, London Times header, is from May 1993, when the victim of whooping cough vaccine won a huge payout for what the vaccine had done to their brain. So what is vaccine encephalopathy? Well, it's the sudden development of encephalopathy with seizures and developmental regression in a previously normal baby. There's long been a claim of a causal link to the pertussis component of our triple antigen vaccine, and this obviously has public health consequences in terms of vaccine uptake and medico-legal implications. Despite this, there have been large-scale epidemiological studies that have failed to prove that there's an association, but if you're a parent and your child starts to fit within 72 hours of vaccination, you blame that vaccination, and often your doctors do as well. So in this study, what we did was look at 14 cases of vaccine encephalopathy aged 2 to 47 years, and 12 of these, in retrospect, had Dravet syndrome. 13 had begun with triple antigen, and 11 had mutations of SCM1A. So we showed that this vaccine encephalopathy was actually due to a genetic cause rather than an immune response to vaccination. And the lack of family history of seizures was because the children had new mutations that weren't present in the family. So at the most, the vaccine triggered a genetically determined disease that that patient was destined to have. And this has societal and medico-legal consequences and is likely relevant to autism as well. So this work has had life-changing outcomes for patients and families. We can confirm a syndrome diagnosis with a gene where we know it. It allows us to optimise treatment, provide prognostic and genetic counselling, and lead to targeted therapies, which hopefully will improve outcome. I'd like to close by thanking the extraordinary team of people I work with, and you can see many of them there at our research retreat, our Australian and international collaborators, and particularly highlight my colleague and fellow, Sam Berkovic, who's a fellow of the Academy, who's been my inspiration and mentor, and really his work has epitomised how clinical research can move science forward. He was recently awarded an AC, which is richly deserved. And finally, I'd like to thank my family for their wonderful support. Thank you.
Thank you very much, Ingrid. Questions? Georgia.
Good. You mentioned that mTOR inhibitors are effective in tuberous sclerosis. Is that for all the manifestations or any? Which?
At the moment, they've been shown to be effective for seizures, the large tumours that can occur, and there are currently trials looking at them for epilepsies.
I don't know who was first. Please.
You mentioned that the vaccine, the DPT vaccine, might have triggered the epilepsy in those with the gene already. I was wondering whether you have any ideas of how the vaccine would have triggered the onset.
We did a further study looking at this, and it showed that there was an association with the trigger, that a third of our Dravet patients did have vaccine-related onset. I had thought it was fever-related. Dravet children are known to often have a predilection to seizures with fever. But in fact, 5 of the 11 or so did not have fever with their first seizure. So I think it must be via another immune mechanism, not just fever. So fever is certainly one, but I think vaccination is working via another immune route.
Fred.
Very nice presentation, Ingrid. Just a small point. In your first type of epilepsy, you divided them into lesional and non-lesional, But, you know, given isn't that just a measure, or couldn't it be just a measure of the resolution of the imaging technique? So the question would be, is there an animal model and do they show neurodevelopmental abnormalities, or in cases that have been unfortunate enough to die as the post-mortem evidence of neurodevelopmental?
Yes, look, I think you're absolutely right that it's only as good as the resolution. Interestingly, many of these patients have had MRI, some have had PET too, and they don't show focal abnormalities on PET, but you do need to look at the brain tissue itself. At the moment, animal models are being made of these, so we will get the answer to that question. And I'm sure we'll get pathology as well, human pathology.
Again, I know there's many more questions, but people will hopefully be able to catch up with you later and tomorrow. Thank you very much, Ingrid.